So thank you all again for coming to harm reduction and overview. I'm going to start with introducing our speaker, Mira Court. She is the Maryland Harm Reduction Training Institute coordinator. Ms. Corey is a Morgan State University graduate with a bachelor's degree in psychology. She has 6 years of experience with the Lighthouse Studies at Pure Point and B Shore. These are 2 harm reduction research programs focused on Baltimore City residents with HIV, STD, high-risk behaviors through the Johns Hopkins University. Mira is a former evaluation coordinator for wraparound systems of care and National Child Traumatic Stress Initiative programs. And this is at the Institute for Innovation and Implementation, which is a part of University of Maryland, Baltimore. And this is where she worked before she joined Behavioral Health System Baltimore. So let me take the time to welcome Mira. Thank you for being here.
Thank you so much, Tiffany, for inviting me to come speak today. And I'm really excited and happy to be here with all of you today. This is a brief overview of harm reduction. This is a truncated version of our Harm Reduction 101 course that we offer. And I'm really excited to share it with you. I'll be going over some information. There'll be some opportunities for you to respond to things in the chat. I welcome dialogue, and then we'll leave time for questions at the end. Okay, so I'm going to go ahead and get started. So let's start with a quick question, and you can put your answers in the chat. Why do people use drugs? What are some reasons that people use drugs? Okay, so we have searching for connections and coping, self-medicating, anxiety, to feel good, for fun, escape the real world. Yeah, you all are like right on the ball. These are what you're putting in the chat are several reasons why people use drugs, and that why people use any sort of substances, and particularly drugs, is it runs the gamut. It runs the gamut all the way from wanting to experiment, just having fun, all the way down to, all the way to the other end of the spectrum, which is, coping with traumas and self-medicating and helping to alleviate internal and external strife. So there are millions and many varied reasons that people use these substances, and all of them are, valid and, important when talking to people and, understanding where they're coming from when it comes to using substances. So here we see just a bunch of reasons. Some are very similar to the ones that you have already given, but here are just a few. And there are, so many others. But, people use drugs, like we said, pleasure and fitting in, leaving incarceration and lack of access to treatment, or stress from childcare or societal discrimination. All of these are reasons and domains for as to why people might use drugs. So when we talk about when we're talking about drugs, let's take a brief moment to take a look at why people um, have stated that they misuse uh, prescribed pain medication. And I put this in here because it's a great information, but also um, specifically because I was talking to medical professionals, I thought this would be um, of interest. The largest percentage for prescription pain relief misuse is to relieve physical pain, and I pause on that because, times there have been, we have all heard stories, both from other physicians or patients saying, like, nobody believes me that I am in pain, like, it hurts. What you're giving me isn't enough, or I need something stronger. For them, regardless of whether it is actual physical pain or psychosomatic, they are in pain and believe them and work with them with that. What's shocking, or shocking to some, but to not to others, might be that only 11.3% are saying that they are misusing prescription medication to feel good or to get high. Um, and if you see towards number 8 and 7, 8, and 9, is that, the reasons that people are misusing prescribed medication is that they need to have the drug or that it increases or decreases the effects of other drugs. Um, so, and this comes from a 2019 SAMHSA study on prescription pain relief misuse. So I just thought that was interesting to get to see some of the reasons that people were giving. Let me know in the chat if this resonates with you or is new information. So when we talk about substance use, I like to discuss it on a spectrum. And so here we have laid out um, the spectrum in a pretty blue and purple linear fashion. And so we start all the way over on the left-hand side of the spectrum of substance use. And that is beneficial use, meaning it has some sort of positive spiritual or social impact. So the coffee that I definitely need every day to get myself going, caffeine, that is a substance. I definitely need it. It is beneficial to me because it gets me up and going so that I can be a whole or mostly whole person for you today. And it increases my alertness. And also, it has no negative social impact really on my life. If anything, it's positive. Everybody loves a good coffee get together, at least in my social circle. And then after beneficial, we move on to non-problematic. And non-problematic is recreational, causal, or like it has really like negligible social impact. Like, you know, my favorite is Snoop Dogg's in town. It's time to go to the concert. There's gonna be a lot of cannabis in the air, you know? So maybe normally cannabis isn't your thing, but it's a Snoop Dogg concert. it's time to let go. Or maybe, a long weekend, getting together, a little, uh, a little what happens in Vegas stays in Vegas type of situation. That's where we are with the non-problematic end of the spectrum. It has very negligible impact on your life, in your health, in your social standing. Maybe you might not want to look at the pictures the next day, or you might have a bit of a falling out with a friend. But in general, things are still okay for you across the board. And then we move into problematic, which is we see two-pronged. So on the left prong, we have potentially harmful. And that's when we start to notice the negative consequences for an individual or for a group. So that means that's covering, binge drinking and, impaired driving. And we're seeing increased risky behavior, riskier routes of administration, um, things that are, you're seeing negative consequences within your social circle. Maybe you're losing friends, possibly losing, work, maybe having brushes with the law. And then the other side of problematic is the substance use disorder as described by the DSM-5 or ICD-9, ICD-10 criteria. And so this is, when things have really kind of spun out a bit and, you know, uh, needs some wrangling in. This is a very chaotic, harmful end of the spectrum, but it is a spectrum. And we like to say that it's on a spectrum, and that since it's on a spectrum, that means you can be at any point on the spectrum with various substances. So it's not just a, all across the board. So you may have a very beneficial, non problematic relationship with alcohol, but you may have a very problematic, chaotic relationship with methamphetamines, right? So many people would say, oh, okay, well, because you have a problematic and chaotic relationship with methamphetamines, obviously your relationship with alcohol is also problematic and chaotic. And as we know, that's not true. Um, Substance misuse, illicit drug use is really the only one of the few behaviors that we have been taught since we were kids, at least me, because I am part of the dare generation that tells you that um, one and done of anything past alcohol, a you are hooked, right? But we're seeing through science and through talking with people that that's just not true. There are people in this world who don't have a problem with substances and using them recreationally, and they have no negative impact on their lives. My favorite example is Dr. Carl Hart, who has made unbelievable strides in science. And then, everyone finds out that instead of unwinding with a, cocktail at the end of the night, you might have a little bump of something. That doesn't negate his intelligence. It doesn't detract from him at all. It makes it's beneficial or non-problematic for him. And so we see it's one of those things where you hear about it, but you never see it. And then now it's very much, he's like the poster child. But there are many people, in this world, possibly in your lives, who are on somewhere on the spectrum with several different substances. So just to briefly touch, many of you may be aware of the change in the DSM-5 criteria and how it differs from the DSM-4. So one of the key things is that the DSM-4 labeled it substance dependence, whereas DSM-5 has now renamed it substance use disorder, or SUD. And also, it added a few more criterion to the disorder. So it now includes recurrent use resulting in a failure to fulfill important obligations, recurrent use resulting in physically hazardous behavior such as driving, and continued use despite recurrent social problems associated with use and craving for the substance, right? So uh, those four new criteria were added as part of the DSM-5 for substance use disorder. And this was added to help better understand and, delineate between um, more problematic use and an actual substance use disorder instead of lumping it all together. So let's talk about drug-related risk and harm. So when we are thinking about substance use, we think about it in three parts: drug, set, and setting. So when we are saying drug, what we mean is the actual physical substance. Is it a powder? Is it a pill? Is it a liquid? Is it a little, paper stamp? Are you buying from somebody that you know? Is it combined? Are you using it in combination with something else, like alcohol or marijuana? Um, Can it be cut with anything? We hear constantly about adulterants in the drug supply, particularly fentanyl. Um, and now we are seeing a lot of the new oh, my mind just blanked. The new pet tranquilizer, xylazine, that has been in the drug supply and the wounds that it's causing. So when we're talking when we're talking to people who use drugs, and we're talking about the drug supply, and we're talking about drug setting, these are all of the things that we need that go into that process. When we're talking to folks about the substances they use and their behaviors around that. The next thing that we need to consider when we're talking about drug-related risks and harms is the setting, or excuse me, the mindset of the person who is using the substance. When you're using drugs, your mindset definitely plays a role in the experience that you have. You like are you what kind of mood are you in? Are you happy? Are you using because you're happy? Like, this is a party? This is like a Vegas bachelorette weekend and we're, doing it up bridesmaid style? Or are we really upset? Are we really stressed? Is this more of, a Nicolas Cage leaving Las Vegas situation? Um, very, depressed, sad, stressed, what have you. Just generally, what type of mood are you in? And then we also need to think about their physical and mental health. Have they eaten? Have they had anything to drink? Are they hydrated? Are they sleeping regularly? It is amazing how much, food, water, and sleep plays a key in drug-related risks and harms to folks. Um, if your physical health is already on a tenuous ledge, substance using illicit substances or misusing prescribed substances definitely makes you more vulnerable. And also mentally, do you have a stable support system? Are you upset? Like, is something going on? Is that part of the reason why you're using drugs? Is this what's pushing you there? Did something just happen? These are things that all go into, potential risks for our folks. And when you are talking to them, you want to talk to them about these things. It gives you a more holistic approach and insight into the person in front of you. And then lastly, we're talking about the setting. So, where are you? Are you public? Are you in a public place? Are you like in a bathroom? Are you in the comfort of your own home? Do you feel rushed? Like, are there cops coming around the corner? Are you feeling coerced? Are you comfortable? Like, do you even know the people that you're using with or around? Do you know who you bought the drugs from? Like, is this someone that you buy from often? Um, these are, again, these are all components that go into assessing someone's risk. If someone is using, let's go back. So if someone is using, say, illicitly bought pressed pills, okay, and they are combining said pill with alcohol, right? Because they just experienced a life altering breakup, right? It was like they just fell out at the bar with their significant other, right? So now we've probably got crying, we've got two substances, we are really upset, and we're at the bar, right? We're trying to do this transaction in public. We don't know who we bought it from. We don't know what's in the pill. We know what we asked for. But we don't know what we got. And see, we don't know, like, you saw cops on the outside of the bar earlier. So now we're feeling rushed. I need to hurry up and take this pill. I'm really upset. I feel scared. And I don't even know what I took, right? These are all things that go into what people are seeing and doing on a daily basis. These are the things that people need to think about and put how people are at risk, and how much goes into substance use behavior. So now that we know what some of their risks are, let's talk about why people don't go into treatment. And this is really important to be cognizant of. And this is very small, and I apologize. I tried to make it bigger, but I don't know if any of you have tried to work with Windows and PowerPoint. It's just not like a lot of stuff. So here in this pie chart, we see, doesn't do the columns. Okay. So we have, as you can see, we have like no healthcare coverage here. We have generally not ready to stop using, didn't have time. We have uh, that treatment may cause a negative effect on their job, that they had health care coverage, but it didn't cover the treatment or didn't cover the full cost of the treatment. So this is just a smattering of reasons why people don't go into treatment. And one of the things that we hear most often is that the type of treatment that that person may want or need is not available in their area. So right now we are definitely in the generation of the opioid, correct? Right? a lot of funding, a lot of help is going towards the opioid crisis in America. Um, and I do air quotes because the United States has always had an issue with substances. um, and um, and so making it seem like it's a newfangled thing. I'm like, this is old news. Um, Not saying that we don't need to do anything about it, but I mean, first, water is wet. It's always been here. And so because all this money is going towards opioids and opioid treatment, where does that leave our stimulant users? You know, opioid treatment doesn't work for people whose main substance is cocaine or alcohol or methamphetamine. And so if that's the only treatment available, then what? What else is there? So, these are things that it's not just because people don't want to or they're just out there doing whatever. Some folks are, but some are just lacking the options needed. And it has a lot of detriment on their life, social standing, work. I mean, so much goes into why people don't seek treatment. So that's where harm reduction comes in. Harm reduction is broken down. I like to break it down into two parts. So the first part is the movement. And the movement is a social justice platform or approach that is built on a belief in and the respect for the rights of people who use drugs. They are people. And we stand with them, we see them, and we are working for them. When we lobby, when we write bills, when we write policies, when we are just generally trying to help the large H, the big H, the movement, the things that we did on November 8th, that's where that comes in. The overarching part. And then we have the small h. And I put it this way, even though I definitely feel to a certain extent that the small h is the bigger dog in the fight, because the small h is the interventions. It is the set of practical strategies and ideas aimed at reducing the negative consequences associated with drug use. So, what I like to say is that the little h, the things that we do every single day in harm reduction programs, such as giving out Narcan and safe syringe and safer injection equipment and such, those are the things that push the big H forward, right? That is the boots on the ground. That is the work that we do every day that collects the data, that gets personal experiences, that the daily, hourly, monthly, weekly change that we see every day, right? And the difference that we make every day that pushes this movement forward, right? And we can't have the one without the other and vice versa. And so I've been a little abstract, but let me tell you exactly, or mostly exactly, because it is kind of a concept of it and an idea. Let me tell you what harm reduction is. Harm reduction meets people where they're at. That means I am talking to and I am discussing strategies with the person that is in front of me, not the person that I want to see, in 6 months, the person right now. Harm reduction is non-judgmental and non-coercive. It seeks to celebrate any positive change. It succeeds due to a one-on-one relationship based on trust, respect, compassion, and dignity. It never requires abstinence, but still, still allows abstinence to be a, valued and, um, available option for folks if they so choose. And it never attempts to minimize or ignore the real and tragic harm and danger associated with licit and illicit drug use, right? So there is this prevailing thought that harm reduction is that anything goes and it's like the wild, wild west. And that's simply not true. It's just that we are meeting people where they are at this exact moment. It is helping them get from take step one to step two. Whereas some folks in general, when helping others, and I mean this both professionally and personally, we don't talk to or treat the person in front of us. We're too busy future thinking. Well, in 6 months they should be absent or they should have cut down, and and then they should be able to do this. So to get to this, we should just do this. That's future person. Harm reduction is current person, right now. You'll still get to treat future person, but right now is who's in front of you. And to not lose sight of that. What harm reduction is not, which is most important to me. It does not mean, harm reduction does not mean anything goes. Harm reduction does not enable drug use or high risk behavior. Harm reduction does not condone, endorse, or encourage drug use. And harm reduction, like I said before, does not ever exclude abstinence as an option, right? Abstinence is always on the table, but it is for the person who uses the substance to make the choice for themselves, not us dictating to the person what is best for them. Okay? And just regarding enabling in general, because I hear this often in my personal and professional life, and Daniel Raymond has a great quote, and he said, "True confession. I got into harm reduction to enable people who use drugs. I enable them to protect themselves and their communities from HIV and hepatitis C and overdose. I enable them to feel like they have someone to talk to, someone who cares, someone who respects them and their humanity. I enable them to ask for help and to help others in turn. I enable them to find drug treatment and healthcare, to reconnect with their families, to rebuild their lives. And I enable people who use drugs to take personal responsibility for their health and their futures. If that makes me an enabler, then I am proud to claim that term." That is a really powerful quote. Because when people are saying that harm reduction enables people, as you can see, it's a double-edged sword. We don't enable any of these things here, right? This is, like I said, this is not what harm reduction is. This quote, enabling people to be their own agents of change, to be active participants in their lives and be upfront and open about the challenges that they are facing in within their personal lives and in regards to substance. Yes, we do enable that. We encourage that. That's what harm reduction is. Now, when we're talking to people who use drugs, we are talking about a group of people who have been through a lot of trauma, typically personal, professional, medical, whether it be, uh, run-ins with the law, excommunicated from their church, kicked out by family, so on and so forth. And so trust might be hard to come by with folks. So you need to create a climate of trust. And I illustrated this with The Virtuous Cycle by Dr. Pauly. And as you can see, it's cyclical, all right? I like colors and I like circles and spectrums. So you can pick any part in the cycle, but typically um, to create a climate of trust with people who use drugs, you want to have a good, like develop good interpersonal linkages. So good people within the system of care, people that you can do warm handoffs up to. Hey, go see Claire over at the clinic. She'll take good care of you. And you know Claire is not going to be judgmental and is going to be open and honest with them. Creating an organizational climate of trust, making sure that your policies are, beneficial and rooted in helping people who use drugs. So, and wherever possible, if people are using drugs between 6 p.m. and say midnight, only having openings between 8 a.m. and 4 p.m., you're not meeting people. It's not helping. And so they may not feel trusted because if you're not available when they need you, you know, rebuilding systematic trust, difficult. These are people who have been shunned, made to wait in ERs forever just because they may have an abscess due to injection, made to feel less than. The onus is on you and your staff and where you are to help rebuild trust in the medical community or in the social services community. And that can be difficult, but once done, it is invaluable. Having a sense of cultural safety, no tolerance for, racism, acknowledging racial practices and beliefs and how they impact people who use drugs and their treatment and their care, and actively combating that. And then having positive outcomes for drug users and communities, letting people see that people who have past and current lived experience with substances are still a valued and part of your organization, your community, and how you deliver services. So I'm going to run through this pretty quickly. These are the principles of harm reduction, and this is from Harm Reduction International. And so the first principle of harm reduction is respecting the rights of people who use drugs, protect human rights of and improve public health for people who use drugs, treating people with compassion and dignity, a commitment to evidence, that the interventions informed by strong body of evidence proven to be practical, feasible, effective, safe, and cost effective, and that it's mostly easy to implement and low cost, and they all have a strong impact, right? So low barrier, low threshold, but also be evidence based, proven, things that work. Like, we know seatbelts work. We know they keep us, safe for the most part in car accidents. That is proven on safety. That is evidence-based. Same thing should apply to harm reduction services. Then we have a commitment to social justice and collaborating with networks of people who use drugs. So not just, you know, locally, federally, making your voice heard at the polls, lobbying, fighting for removing unnecessary barriers, including people who use drugs in designing, implementing, and evaluating your programs and policies is crucial. Uh, the avoidance of stigma, using respectful language and avoiding stigmatizing terms, and some of the goals of harm reduction. Harm reduction recognizes that many people are unable or unwilling to stop using drugs, and that's their choice. That is their choice. And some do not need treatment. Others who experience drug-related problems may be unable or unwilling to access abstinence-only treatment. And as a result, harm reduction centers on quality of life for metrics of success and not the cessation of use. And it keeps people alive and encourages people to work on healthy behavior change. It's facilitative versus instead of coercive. It reduces the harms of drug laws and policy and offers alternatives to approaches that seek to prevent or end drug use. Again, you can prevent or end, it's that person's choice. But those are the goals of harm reduction. So it's working with people collaboratively instead of a top down, I know best mentality or approach. So, what does harm reduction look like in action? So, up at the top left, you see housing access. That is the housing first model. Um, people, people's drug use change when they are safely housed. Some people who are unhoused, they use drugs for safety or to keep themselves up at night, so that people don't assault them or steal their things. If you put them in a home and they can lock the door, you may see changes in their use because you have checked off one of their crucial reasons for use. Pharmacy access. So some places have access to get Narcan or syringes at extremely low barrier or no cost. We have medication assisted treatment such as methadone or buprenorphine. We have overdose prevention such as Narcan and trainings on how to use Narcan. Safe consumption sites, which are very, very much in the news lately. We've had have one in Philly. I believe there's one coming soon, also still on the East Coast. I'll have to check on that. Syringe access programs and syringe disposal. So those are your syringe service programs. And connections within the medical community, good referral networks to different programs is also what harm reduction in action looks like. So I wanted to open the floor now for questions. You can put them in the chat or you can take yourself off of mute. Oh, you're welcome, Zoe. And I realize I might have gone through a little quickly, and I apologize. But it's a lot to cover in a little bit of time. Okay, so we have a question. How does this apply to bystanders, like involved children, as opposed to parents who are using drugs? So when we're talking about bystanders, and in particular, with this question about children, one way to help and meet people where they are is if you know that there are children in the house and maybe they are parenting their parents in some ways. Narcan itself is non-toxic and easy to use. Teaching people, teaching children how to use Narcan in case of an overdose is life-changing. Not only is it empowering for the child to not feel helpless in a time of crisis, but knowing that they can help. Um, and also, it helps if it's just a situation where it's just a parent and child. Also, being aware of your state's Good Samaritan laws is also important. And that goes for the bystanders of adult, meaning adult bystanders, bystanders who are watching an overdose happen or in the presence or maybe alcohol intoxication. Knowing who is needed at the scene and what to say when you're talking to EMS is important. But knowing your Good Samaritan laws can actually really, really be helpful in making sure that your people know them as well. Next, we have a question is how many substance use disorder inpatient treatment centers teach or condone the harm reduction model? I will be honest with you, I do not have that statistic at the moment, but I will look into that for you. But I will say that um, just by doing this type of work for many years, and we have a lot of folks who work in the abstinence only model for a treatment center because that's the only model that inpatient will allow. They have been making more connections with harm reduction programs because they know the stages of change and that, you know, going returning to use is part of the process. And so to not just have someone, you know, leave the program, what they do is they make these connections with other harm reduction programs and do a warm transfer, a warm handoff. Like, okay, hey Mike, we have a zero tolerance policy here, and your analysis came back showing, opioids, and we can't have you here. But we're not gonna just throw you to the wolves. We're gonna, have you go to this harm reduction program, and they're going to help you and they're going to keep you safe and help you until you make a new decision. um, let's see, so many treatment methods are abstinence based, and that's if you can even get into treatment facts. How to get clinicians to embrace evidence-based methods centered on harm reduction. Ooh, look, this is why I'm here talking about this, talking to medical professionals about harm reduction, having them see it work in action, coming to talking with other medical professionals who already have bought in to the evidence-based methods of harm reduction is crucial. I just attended the National Harm Reduction Conference in Puerto Rico, and I went to a fabulous two sessions one was by a Dr. Christine Nichols, and she is a pain management physician who also has her own experience with long-term pain management, and she gave a fabulous discussion on how pain management is is harm reduction and looking deeper into that. So I would love to share with you some of the names of folks who are in the medical professional who are on board to talk about, what language speaks best um, to folks. How do you engage with people struggling with problematic substance use, but who are engaged with an abstinence program like Al-Anon or Narconon and still having trouble? So, what I would say is I would talk to the person who is having problems and say, hey, I see that you are having some, struggles staying with this abstinence-based program. Talk to them why they started there or why they are there and what is continuing them to use. Where is the disconnect? And really discussing with them where they are and maybe having a suggestion as to what a better option for them might be, what that might look like. Um, and sometimes that's not feasible because sometimes they're court mandated, but working within the parameters that you have is the best.
We also have a question from Hannah.
Mhm.
It started coming through really quickly and we're running out of time, but Hannah says, thank you for the presentation. I work in a library and I took this class as a way to help me know how to best reduce harm when talking and creating relationships with patrons that come into the library. If someone comes to me and looks for resources on helping them reduce their drug use, what other resources would you suggest I supply them?
Certainly. I will. Do I have a resource list? No. Okay. So, um, I will put in the chat some websites and trainings filled with information that would be helpful to many people. Um, uh, and um, so both sites, so one unabashedly is my organization, and we do a lot of trainings on um, all different topics regarding harm reduction. The National Harm Reduction Coalition, which is the next site that I listed, also has lots of information and resources, a huge resource library. My contact information is here. And I work on a team of 3. So it is myself, Saul Corbin, and Ray Alcastabani. And we all teach on harm reduction, different areas, from drug checking to restorative justice and motivational interviewing. But we also there are lots of different locations. There's also the Florida Harm Reduction Coalition. Um, and the director there is Tim Santamore. And for those who were in Florida, I saw Florida come up. And so that organization would be good for resources. Please feel free, um, either after this webinar or when the recording comes out, please feel free to reach out to Marty, reach out to me. I would love to help anyone who wants to help people who uses drugs, and make them feel comfortable. And so I'd love to help empower you all to become harm reduction enablers. Come join me, won't you?
Well, thank you so much, Mara, for coming. It looks like we have a lot of happy participants that are still here with us.
Thank you so
So
much.
again, thank you all for joining us as well. And it looks like we have one more minute. If there's one quick question I see pop up like in the next couple seconds, but if not, I just want to say thanks again, and that will be the end of today's presentation.
Yes, thank you so much for having me, and I would love to hear